Welcome, everyone. My name is Corinne, and I will be your moderator this evening. I'm excited to welcome Dr. Stephen Vorholt as our speaker this evening, and he will discuss 3 different types of surgical guides and how to make them in-house. Please note that CE is not available for tonight's webinar. Dr. Vorholt, welcome, and thank you for being with us tonight. I will pass it on over to you.
All right. Thank you for the intro. I'm excited to talk about this. This is something that I talk about frequently, but I'm trying to come at it from a different angle with some of my newer content. So I think we're going to break down surgical guides into a more easy to understand paradigm and different way of kind of thinking about them more globally and kind of how they could work for you. And then I'm excited to talk about how to make them in-house, because since 2016, I've been 3D printing in my own private practice. And now with what I do, I also 3D print surgical guides. So let's get right into it. For those of you who don't know me, my name is Stephen Vorholt. I graduated from The Ohio State University in 2013, and I quickly did I was an associate for 2 years, then did a private practice scratch start in Columbus, Ohio. That's when I first started doing implant. I left Ohio in 2020 and moved to Arizona to work in implant education full time. So I was lecturing across the country. I was doing live surgical mentoring and also helping to manage a clinic that was doing a lot of dental implants. And then most recently, I've gone back into the private realm, and I'm a traveling implant surgeon. So I stay around the Phoenix area, and I take all the stuff with me in my car. My assistant meets me at the office, and I travel to 6, 7 different offices throughout the month, and we just do surgery and then we go home. So I have no brick and mortar place anymore. However, you can probably see behind me, and we'll talk about it in more detail towards the end of the webinar tonight. I do have a 3D printer here in my home office. So with the offices I work with, they are able to send me the CBCT and STLs, and I can make the 3D guides myself and bring them with me. So this is kind of what my home office looks like behind the scenes. So I have a lot of these Milwaukee packouts that are just stuffed full of armamentarium, instrumentation. I have a Medit scanner that's tucked away in there. I have an implant center 2 from Acteon. That's an implant motor, piezo motor. There you can see my 3D printing ecosystem. And then the setup that I'm looking at, which is the 2 screens and all that kind of fun stuff. So this is where I work when I work from home, either doing surgical treatment planning or kind of doing consults or webinars like tonight. This is kind of where I live now. This is my office, which has been a lot of fun this year. So tonight's webinar, we're going to talk about a couple of things. We're going to briefly touch on the rationale for guided surgery, why you should or shouldn't be doing it. We'll talk about the workflow, which I think is really important for everybody, dentists, assistants, lab techs, to understand the concepts of surgical guide design. Not just here's a surgical guide, here's how you use it, but how does it get fabricated in the first place? Because if we're giving bad data to our lab tech or our assistants or to ourselves, we're going to have bad outcomes. We'll talk about the types of guides. So I break down guides into the 6 main parameters or things that guides can actually do for you. So we'll talk about what those are and the different options for guided surgery. We'll then touch on full arch guides, because that's kind of its own thing on the side, and the 3 different techniques for doing these full arch guides. And then I'll give you a video walkthrough of the Sprint Ray in-office workflow itself. So let's talk about guided rationale. So what's the argument for guided placement? Well, number one argument is probably reduce surgical time. Okay, it's going to make your surgeries and the actual time spent in the chair with the patient go faster. And we all know time is money. So it might take a little bit more time outside of the chair, treatment planning, or if you're using a lab, to have that fabricated in the meantime. But the actual surgery itself, the time when you're actually seeing the patient, it can be reduced. Less complications, especially when we talk about future restorative complications. Since we're putting the implant in the ideal spot, we're going to have less restorative outcomes that are non-ideal. So we'll have more screw retained crowns, for instance. We'll have better access for occlusion, so less screw loosening, less chipping, that kind of stuff. Lower stress for yourself, your staff, and the patient, which is always helpful, and increased revenue. So we can charge for this. There's CDT codes 6190, which is the surgical stent code. Average cost, I would say, is about $300. And if you're doing this in-house, your cost is probably closer to $20, $30. If you're doing it with a lab, it could be in the $100 to $200 range. There's still revenue to be made there, and certainly you should be charging for this service that you're offering. If you're a highly PPO driven practice, I've heard of some practices that also use the 0470 diagnostic cast code to get a little bit more, since they have to kind of do that itemized billing for the initial scan. So the intraoral scan, it's a diagnostic cast. It just happens to be a digital one. You're also going to be bringing your plan to life. So most courses that you're going to take, if you ever took a course from me, is going to be all about treatment planning from the crown down, basically. So we want to know where our end result is, and that's how we plan where our implant needs to go. So if you've already done all of that work, especially if you've gone the trouble of having to wax up and kind of idealizing where the implant's going to be, it's one or two more steps to actually get a physical manifestation of that plan in the surgical guide that helps you actually execute what you had already spent so much time planning. And I say pilots to prosthetics because guides today come in so many different shapes and sizes, from a single drill guide that just gets you started in the right spot to a set of guides that is quite complex and can be complicated, but it leads all the way to the immediate load prosthetic that's been pre-made for you. So it just kind of depends how much you want to dip your toes into the guided surgery realm. Some limitations we want to talk about always. Drilling on a slope or against a hard cortical plate can deflect drills, and that is not something that goes away with guided surgery. The problem with guided surgery is you might not realize it as much. And so we can get into situations where our drills got pushed in a direction we didn't want them to get pushed, and we didn't know about it, which is can be more of a problem than it would have been if we just attempted it freehand. Immediate implants. Some immediate implants work really well with guides, some don't, for the same reason we just spoke about, drilling on slopes. A lot of sockets are not straight up and down or flat bottomed, but it also takes a little bit of time. So if you get really, really fast with the technique of being able to scan the patient, design and fabricate a guide, you could probably do it in under 2 hours. But if a patient comes in on 3 p.m. on a Friday, and of course they've got the wedding tomorrow or the graduation or whatever it is, sometimes guides are not going to be the most efficient way to get the surgery done. There's less flexibility because if something goes wrong with the guide, you probably can't use that guide anymore. And you have to be willing and able to put the guide aside and go back into critical thinking mode with your freehand surgery. There's a little bit of issue with saline or lack thereof. So lack of irrigation, because most of our drills are externally irrigated. So the water is coming off the handpiece and kind of aiming at the tip of the drill. Of course, with the surgical guide in the way, the saline's not getting there. So there's some ways to mitigate that, but we just have to be aware of it and probably change our technique with drilling to be a lot more exaggerated pumping to allow some saline to get down to the tip of that drill. Less visibility, less tactile sensation. Guides are not completely transparent. They're usually a little bit opaque, so we can't always see what's going on underneath the guide. And kind of the same situation with the drilling on a slope and against the plate, the tactile sensation is a little bit lessened or dampened when working through a guide. And then some patients just can't tolerate guides. Some patients can't open wide enough or can't stand to have something in their mouth or for whatever reason. So let's talk about the workflow real quick. When you get a patient in, first we have to diagnose the patient. Irrespective of what you're going to do, we're going to diagnose the whole mouth, right? We don't want to just treat the one spot that's empty. So we're going to treatment plan based on their medical history, their dental history, and their teeth complaint, and look at all the factors that can affect that. We're going to take a CBCT scan, and you should choose an appropriate field of view based on what you're trying to accomplish. However, you should not go for a 5x5 quadrant scan if you're doing an implant if you've never taken a full mouth scan. So if it's the patient's first CBCT scan in your clinic, I recommend getting the full field of view because you want to diagnose any other potential issues around the mouth that might be more urgent than a elective implant number 19. So a full field of view CBCT might show us abscesses on other teeth. It might show us chronic sinus infections. It might show us pathology. So we always want to have that as your initial CBCT. After the surgery or after the patient's had their initial screening, maybe 1 or 2 years ago, and something changes, then by all means, let's take a more focused field of view. So we have our CBCT. We're going to read the CBCT. Every time you take an x-ray, you are medically legally required to read the entire contents of that x-ray. So let's look for all pathologies, not just zoom straight into where we're trying to be working. We're going to bring in our intraoral scan. So this might be from like in my case, a Medit. It could be from your Omnicam, it could be from your PrimeScan, your Trios, your iTero, whatever. But somehow you have to get that digital file, that STL, and bring it into whatever software you're using to plan your surgical guides. So I use Acteon software. That's the CBCT brand that I'm a big fan of. And inside of their own software, they have what the screenshots we're looking at. They have a guided creation portion as well. So we overlay the STL, or the intraoral scan, over the 3D rendering of the patient's jaws. And that allows us to now bring in the data that's more accurate to the patient's, actual intraoral presentation and their gums and soft tissue and contours and such like that. So once we have that, we can ignore the 3D rendering, and now we can treatment plan based on the patient's intraoral presentation. So we're going to look at anatomy. Certainly, we want to map the nerves, if there's any nerves in the place where we're going to be working, and we should do a wax up. And if it's a simple case like this gentleman's case with number 19, most all of us, I'm sure, can do mental wax up. We kind of know where there's an edentulous span with adjacent teeth, where the tooth's going to go. But it is nice if you're working in a software, especially if you're doing adjacent implants or a longer edentulous span for 2 or 3 teeth, to actually get a proper digital wax up. And this doesn't take long. You can do this in a matter of minutes. And just to get the proper spacing and at least a good idea of where the teeth should be, so that you know when you're planning your implant. So in his case, we have a little wax up tooth. And what's important to understand about guided surgery and the softwares is that STL overlay is really important, that it has a good stitch. And by that, I mean it has to be accurately overlaid on the patient's x-ray. Because what we're looking at here is the STL overlay, or the soft tissue level impression of the patient. And then what we're really worried about is the CBCT that's underneath it. So we're understanding that while we're looking at the gums and the teeth, and that's what we're going to build our guide on, that's what things are going to seat on, we're actually more concerned about what's underneath all that tissue, right? So that's why the stitch has to be so accurate. So first things you want to look at, we do our wax up, we plan our implant to support that future restoration, whatever that is, if it's a crown or an overdenture or a fixed bridge. And then we double check the CBCT data and the x-ray and make sure that we're not violating any biology, whether that's anatomy, undercuts, adjacent teeth, angulation problems, enough blood supply, and so on. So we look at the buccolingual, we confirm the mesiodistal, we're well away from the nerve, we're not going to hit any other teeth, we have a good angle. And then we go back and we make a guide. So most of the time, we've already done steps 1 through 8, just when we're treatment planning implants, right? We've put the implant in the software, we are confirming that we have enough space, biology, that we like the length and the width of the implant we're going to choose. And there's only one step left to go, and it's create the guide. So now we've gone back in whatever software we use. We tell it, we're going to use a BioHorizons implant here, so it knows what the guided sleeve looks like. And we're just going to fabricate what is essentially a night guard with a hole in it. Okay. And there's different designs we can do. Like in this example, you can see we put some windows in it just to help confirm that it's fully seated when it's in the mouth. But essentially, we've done 1 or 2 more steps after everything we've probably been doing anyhow, and to make something that's a digital and then turn it into a physical surgical guide that fits in the patient's mouth. So that's kind of the workflow for surgical guide creation in a nutshell. Let's talk about guided parameters. So what can guides do for us? Well, they can certainly help us with position, right? That's kind of what I think most of us think of immediately when we talk about guided surgery, is what position we're going to put the implant in. And by position, I mean the entry point into the ridge or crest of bone, mesiodistally and buccolingually. So this is like the bullseye we're looking for. Angulation, which is the long axis of the implant, right? All the way from tip to top. We have to know what angle it's going into. And then our guides can help us with depth, right? They can stop us from over drilling, especially important if we're worried about sinuses, undercuts, nerves. And then certain guides can also help us with width. So we can have a guide that allows us to use all of our drills, including our width increasing drills. And that might get us to a complete osteotomy that's ready for an implant. Other guides can also allow you to do placement through the guide. So what we typically call fully guided surgery, which means the implant itself also goes through the guided sleeve. And that can help you with timing and precise angle and depth of the actual implant body itself, which leads to, if you choose to, a prefabricated prosthetic for immediate loading. So if we know all of these things, the first 5 things, the position, angle, depth, width, and placement of an implant, and everything goes well, we can pre-make whatever tooth or temporary or custom healing abutment that we wanted, because we're so assured that the implant is going to be exactly where we planned it. And so that's kind of the level, the 6 parameters of what guided surgery can do for us. So let's break that down into kind of the different options. Okay. So if we're looking at just position, there are a lot of analog models. These are old school. These are maybe before even CBCTs were super popular, but there's a lot of devices out there. And this one in particular, you can buy for like $7. This would be a very analog, non-digital way of doing things, where you have this nice little wedged feature that just shows you where the middle is between 2 teeth. It even shows you kind of what the width is between the 2 teeth. So the little tool that's on the upper right would help you for multiple implants, whether it's 2 or 3, to make sure that the spacing is correct. There's a couple different varieties of this, but essentially the important thing is all it's doing is telling you the position, or helping you to put the implant, the initial bite, in the middle of the teeth that that are adjacent to it. So that's just positioning devices. How about angulation? Well, some of the original quote unquote guides, which I don't like to call these guides because they aren't really guiding anything. They're not physically holding you accountable with your drills, but these are surgical stents. Let's call it that. So we're doing essentially an Essex tray with a tooth wax up. So we do a wax up, we do an Essex over it, and now we can bring that Essex into the mouth. And what it shows us essentially is just a physical wax up. So this can help you with position and angle. So ideal position and angle, so that we're coming out the central groove of where we assume or where we're planning on putting these teeth. The big issue here, of course, is there may not be any relation to the CBCT in this. This is still an analog model. This was just done on a stone model with an ideal wax up, and you take it into the mouth. So who's to say if that upper right photo isn't approaching a lingual undercut and potentially going to, perforate the lingual plate in the first molar region, or is going to come near the nerve? Because how do we know where the nerve is? Maybe just on a pano. So these have a limited usefulness. They're better than nothing, maybe, but I also think they can give people a false sense of security. So you used to see this a lot in dental school 10, 11 years ago, when the pre-grad students would have to make these for the specialty clinics. And the one time I made one, it didn't even get used. It was put in the mouth. They looked at it, and then they tossed it in the trash can. But I think the usefulness of these are overplayed in some people's minds of how nice this actually is. What about depth? You can get drills that have built-in depth stops. What you're seeing here in the video is a BioHorizons 2.5 depth stop drill, and they come in all 5 sizes of their implants. So from 7.5 up to 15, and you can see the little kind of depth stop, the little ring on the top of the drilling portion, the cutting portion, and that just bottoms out on the ridge and doesn't allow you to sink past it. And so you kind of have a little bit of control on the final depth. So this is nice if you know there's a certain depth you want to get to, and you can really just focus on the angle and position. So when you're doing freehand, you can focus on the angle and position and be less concerned about also checking the depth, because you have depth stop drills. Now, there's other kits like the one you see on the right that have a multitude of these sleeves, and these sleeves actually fit over the drills. And so what's nice about this is you don't have to buy 6 drills of every width for a depth stop on it. You have the different sleeves that will fit over and slide onto an otherwise totally normal freehand drill. And so there's ways that, if you're not into guided surgery, maybe you're not doing CBCTs or don't have an intraoral scanner, or you don't have the access for a guided kit, this is one way to kind of take away at least one of the 3 main components of implant positioning, which would be depth. If we were going to combine all 3 of those, this is where we start to get into what I would call a surgical guide. So this is actually something that's guiding you. So if you want position, angle, and depth, a pilot guide will give you all 3 of those. And what a pilot guide is it's just a 2.0 typically sleeve that just allows you to place your pilot drill through the sleeve, and it'll stop you because it's going to hub out on the sleeved part of the guide. And so therefore you get position, angle, and depth. And then once you're done with that, the guide gets put aside and you complete the osteotomy however you choose, whether it's with other depth stop burrs, whether it's with freehand drills, whether you just use osteotomes or Versa or whatever it is. But this is just helping you take, which is probably the hardest part, is that initial ideal angle, position, and depth. So this is a great way for people to get into guided surgery. They're also less expensive, which is great. But guided pilot drills are a really, really nice intro. And I use them, I would say more than half the time that I'm doing guided surgery, I'm just using a pilot drill because it's so nice. You can punch right through the tissue with these if you choose to. You can do a little flap first. A lot of different ways to use pilot guides. So this case in particular was a young woman who had a congenitally missing 7 and 10, and another surgeon had done some grafting. So we can see the grafting on the onlay GBR there. And it was my turn to put the implants in. So we placed them deep enough that they were going to be in the thicker part of the bone. And keeping in mind that they were congenitally missing. So this little peak of bone is not typically there, right? That is there only because the adjacent central and canines had erupted and brought that bone with it. So when we did the surgery, we made kind of a scallop to the bone anatomically, as you would expect, and placed the implants simply with a pilot drill, and then the implants went in. And it worked great. So it's, keep it simple. If we go to guided surgery now, so now we're introducing the ability to control width increasing. Okay, so we still get position, angle, and depth, but now these sleeves are larger, and guided kits, allow you to use different width drills there. So you get complete control of the angulation all the way to the final width of your osteotomy, which is great. This is really nice for future implant, like future bridges and adjacent implants that need to be pretty parallel so that the restorability is going to be simple. And they're faster surgeries because it's predictable. It's one less thing you're thinking about necessarily. There are some downfalls to it, of course. Space limitations. These sleeves are quite a bit wider. So rather than a 2.0 sleeve, which is maybe 3 millimeters in diameter itself, these might be up to 6-7 millimeters of diameter. And not all spaces can accommodate that, especially if they're adjacent implants. Limited patient opening. Sometimes patients can't stand to have 24 millimeter drills of all different widths going to the back of their mouth. So that can be difficult. These are more expensive to design. And because the sleeves are more expensive and a lab is going to charge you more for this if you're doing a lab. And they also require a separate guided drill kit. And that's probably the most expensive part is, whereas the pilot drill, you could certainly buy individual pilot drills that have depth stops that can be used for pilot drill guides. And that might cost you, between $60 and $100 a drill. So maybe you get 4 different lengths. Or you have to buy a fully guided surgical kit, which can cost thousands of dollars because you need all the drills have to be guided. So a little bit more expensive to go with this route. But a case that we use this in, where we're doing the guided, a portion here for a distal extension, so 2 molars. And you can see we did guides to get the osteotomies in the right spot of where they needed to be for future crowns, and simultaneously did a GBR so we can see some perforations in the buccal plate. We're getting some additional bleeding to get the progenitor cells there. And then we're going to graft around it. Okay. And so after 5-6 months of healing, she came back, uncovered it. We moved the tissue from the lingual to the buccal to give a nice band of keratinized tissue. And there we can see our final restorations that were ideally placed, right? The access holes are coming out the central groove. So that's a nice way to use guided surgery to allow you to get to full depth. And in a case like this, where it's adjacent implants and we want them to be nice and parallel to each other. The last type of guided surgery when it comes to singles is fully guided surgery. And so I mentioned this earlier, but fully guided surgery is when we're doing everything through the guide, including the implant placement itself. So the implants are going to go through the guide as well. So in this case, we have a 3-tooth or 4-tooth, edentulous span, and we're going to do a bridge. So all 3 implants will be bridged together. And we've got our plan. We've got our wax up, and see, the wax up is not anything super fancy. It's not perfect, but it gives you enough information to get the ideal spacing, especially when it comes to different size teeth, right? So premolars and molars. And then we have our guide creation here with a window at the midline. So the patient comes in for surgery. We do a flap. You can notice in the middle picture how the flap itself is being held back by the guide. So gently held back, release the flap as normal, and then hold it back with an instrument while you seat the guide, and that allows the tissue to stay out of the way. And you don't always have to do this, but sometimes we'll take off the guide just to double check, trust but verify with our pilot parallel pins. The implants all go through the guide themselves. So here on the left, we can see these are guided carriers. So these attach to the implant and they are also guided. So when they go through the sleeve, they're kind of held in their position and the implants are in and closed up. And so this, these implants went in all three nearly parallel to each other within 3 degrees, and the bridge was later fabricated without too much trouble. And then finally, if we go up the final step out of the 6 parameters, we can make a preformed prosthetic. So if we already know the guided placement, the depth, and the timing, which is the rotational axis of the implant, and that's going to tell us where the internal hex lies. If we can get the timing to be perfect as well, then we can prefabricate, even pre-mill and pre-lute prosthetics. So in this example, we've pre-printed a prosthetic, and what this prosthetic was a kind of Maryland wing pontic with a hole in the middle of it. And so it was set up knowing where the guide case was going to take it. So here we can see our guided plan. We're going to place a 4.2 x 12 implant. And because we know where that implant's going to go, we can have this winged bridge pre-made, which you see on the right here, just resting on the occlusal surface and the cusp of the canine. And with no adjustment at all, implant goes in, this slips right over the top. It's got a 4 millimeter diameter circle kind of bored out and printed for the 3 millimeter diameter temporary abutment. So with no adjustment, that slips right over. We lute it together with some flowable composite. We take it out of the mouth, polish it, get the contours correct, and screw it in, keep it out of occlusion, and suture. And now we have a very, very quickly made like preformed prosthetic rather than making it completely out of bisacryl or any number of reasons. You could take this one step further. And like I said, if you had the timing and everything perfect, you could have something pre-luted, completely made on a tie base or something similar to that, that would allow you to just screw it in right at the end of the surgery. So if surgery goes well with guided surgery, it has a lot of options, which is great. So now we know kind of the 6 parameters. Let's talk about the 3 types of full arch guided, because even if we're not doing guided surgery when it comes to full arch, it's important to understand kind of what the modalities are for this, right? Because that's why dentistry is a professional job, right? Because we have to understand everything. So there's 3 different types of support. And so support is really important for guided surgery. It's all about, where does the guide rest? How do you know that the guide is fully seated? How do you know that it's going to be accurate? So we have tooth-borne, tissue-borne, and bone-borne when it comes to full guided. So first we'll talk about tooth-borne. Tooth-borne is probably the most predictable. This is similar to what we've just shown with the pilots and the fully guided. We're using the patient's own hard tissue in their mouth, which presumably should be stable, to rest a guide on. And we can get a good scan of that before the surgery so we can fabricate everything. And so in full arch, of course, we're going to be removing the teeth, presumably. So we have to usually think of like selective extractions. So which teeth do we want to keep? So first things first, we get all of our data. We plan the implants where we want the implants to go, not really concerning ourselves with so much about how the guide's going to be made, but make sure the implants are in the spot you want them to be. And then we can take a look at the plan and see if that allows us any flexibility to either do tooth-borne guides or if we need to do a bone level guide. So here we can see our implants are planned in the roughly the second premolar region in between the incisors. So what we can appreciate when we see our guided plan is that they're not inhibiting the canines or the molars, right? The implants and the guide sleeves aren't going to touch the canines or the molars. So we could do some selective extractions and leave the 2 canines and the 2 molars and use those as our support for our guide. So what we do is digitally extract the teeth that we're not going to keep. So in this case, we digitally extracted the premolars and the incisors, and you can see that digital model, the orange model here. And then we can see the intraoral photo as well. And we have to do some selective alveoloplasty too. So there's a guide that isn't shown here that kind of snaps over the teeth, and it just gives you an idea of where the alveoloplasty plane is. So after the flap, that guide goes on. We draw a line with a sterile carbon pencil, and then we can do some significant alveoloplasty so that the guide seats on the next portion. So here's the guide in the mouth and the design. So it's designed, like I said, to sit on the canines and the molars, and we can see in the mouth how that worked. So here, that's why we had to do some alveoloplasty first, so this would seat between the teeth. And then we can do our fully guided drilling with strong support like a tripod support of these teeth, which is really useful. After the implants are in, then we remove the remaining teeth and graft the sockets and close. So that's a really nice way to do it. If possible, it has to be the kind of case where you're not going to have implants that are angled or going to otherwise hit or inhibit, those teeth still being there to support it. Other types of support, tissue-borne support. So this usually comes up if somebody's been a dentulous for some time, they already have a denture, right? There's no teeth to support anymore, or the teeth are so broken down or are just root tips that they're not going to be helpful. Not going to be something that you can support anything on. So we have to do what's called a dual scan. So the dual scan protocol is for dentulous patients, and we buy these stickers. You can get radiographic beads from Suremark. That's what I use. You could use melted gutta percha points, little composite beads. The Suremark stickers seem to be the most predictable in my hands, but we take the patient's denture. We make sure it's a well-fitting denture. That's really important because the guide will only fit as well as the denture does. If it's not a well-fitting denture, or it could use a reline, and you don't want to wait the time for a reline, get yourself some green mousse sold by Parkel. And the green mousse is just a wash impression, a little bit of polyvinyl adhesive, some green mousse, sit it in the patient's mouth, have them fully bite down or have it fully seated. And that's a radio opaque bite registration material. So it's really nice because it's going to give, in the x-ray we're going to take, it's going to show us the ideal contour of the patient's soft tissue. So what we're going to do is we're going to do that reline. We're going to scan the patient wearing this denture and the radiographic beads. And then we're going to take the patient's denture itself and scan it by itself. So the bottom right photo on this tab is a CBCT rendering of just the denture, right? So it's not attached to the patient. And what we can do is we can merge the two in our software. So here we have the patient. And of course, because we hit them with enough MA and KVP, the acrylic of the denture doesn't show up, right? We're seeing hard tissue, bone, and whatnot. But we do see the radio opaque liner of the green mousse, which is kind of what this material is. You can kind of appreciate this rolled up in the vestibule. These little dots out here in space, those are the radiographic beads or markers. And so we can now bring in that second scan, and using those little radiographic markers or beads, we can say this point matches that point, and we can now have, like we have on the top right, have a denture that's sitting over a hard tissue scan. And what's so important about that is you can't see soft tissue in a CT. So building a guide on the bone is okay if you're doing a bone guide, but if you want to have something that fits like a denture on a patient like this one who doesn't need a lot of alveoloplasty, this is a really nice way to do it. So then we can bring that in. Really useful for the dentulous maxilla, not great for the mandible because, as we know, mandibular dentures don't fit very well. So a mandibular denture-based guide also won't fit very well. Just won't have a very good security. You can do some pins to hold this in place if you choose to. If it fits well enough, you can usually just hold it against the palate. And I like to use these for pilots too. So in this case, we're planning it just for a pilot guide. And we'll probably just punch our pilot right through the tissue, assuming we're in a band of attached tissue. So put the guide in, mark it with a little Thompson stick or a perio probe, see where it is. If it's in a nice band of attached tissue, we'll put it back in the mouth, drill right through the tissue, and then proceed with our flap and alveoloplasty and so on. So that's a soft tissue borne guide example. The last one we'll talk about, bone borne, is a little bit more complicated because it requires bone segmentation. So we need a nice CBCT rendering that we either send to a lab, do it manually ourselves, or nowadays we can use artificial intelligence, machine learning through a couple of different programs online to get a rendering or a model of the patient's jawbone. And off of that bone, we build guides. And so this requires a much more extensive flap. You have to be very comfortable with pretty big surgeries for these to work because we're going to be flapping well above where we're going to even do our alveoloplasty to, so we can seat this guide. So this example we have, the orange model is the patient's bone, and we've made a guide that functions in a couple different ways. This is a foundation guide is what I call them, but it serves as an alveoloplasty plane guide. So once it's fixated in the bone, in the mouth, whether the teeth are in or not, we can use that as a guide to get our plane correct for our alveoloplasty. So the bottom right you see is kind of the designed version of the post alveoloplasty. So in the mouth, here's what it looks like. And you can get a pretty intimate fit with these. It's gonna be pretty impressive the way that these segmentations work anymore. The technique then is you have this alveoloplasty guide, like I said, and you can see between the pins are these little connectors. And what these connectors do is they allow what's called a stackable guide. So once the alveoloplasty is done, then we can stack another guide on top of it. Of course, while the bone's still there, nothing will fit. So first step is to pin this in place, do the alveoloplasty, remove the teeth if needed. And then here's what it looks like in the mouth. Okay, so we've done our alveoloplasty to that level. And then we bring in the stacked, which in this case is the darker guide. Then once the bone is out of the way, this can now fit on top of that. And this is where we'll do our drilling. In this case, it's a pilot guide just to get our angles started. And in a lot of full arch cases, fixed stuff, I don't do a lot of fully guided because I want to feel everything, the tactile sensation. I want to know how much to undersize or where to manipulate bone. So a lot of times I'll do this with the pilot guide, but the technique is the same. Okay, so here it was after pilots and then implants in, and this is where they torqued out at 32 newtons. So I went back and finished with some hand ratcheting to get these into place. And that foundation guide also serves the purpose of holding back the lips and the tongue, not the tongue, but the lips and the cheeks and the flap as well while you're doing all of this work. And then that gets removed and you move forward with, whatever your prosthetic design was in that case. Okay. So how do I make these in-house? I use the Sprint Ray ecosystem. I have a Pro 95S and the curing unit and the wash station. And I want to show you a video that I made a week ago that's just showing step by step how I do this in-house. So please enjoy that. And then I'll pop back on at the end here for some final thoughts. All right, welcome to my in-office printing station. This is in my home office. This is where I do all my printing for my traveling surgeries. I just want to walk you through the step-by-step for surgical guide creation, all the way from setup, print, wash, dry, sleeve insertion, and cure. So on our left, we have the Pro 95S, which is the printer that I have in my home office. Right next door to it is the wash and dry station that we'll use after the print is done to completely remove all the excess resin. And then we'll do some sleeve insertion here on the desktop, and finally put things into the Procure too. So first things first, let's head back over to the computer and set up our print. Okay, so we've loaded up Rayware Cloud, which is the cloud-based software for the printing. There also is a native desktop app in case you didn't have internet or the internet was slow that day or what have you. But the cloud is really nice because it'll save all of your old files. It also has better supports, and it's got some AI generated stuff for aligning things on the build platform and such like that. So if we were to bring in several things at once, maybe 10, 12 models, it'll do all the thinking for you on where to put it on the build plate, which is great. If you have Rayware desktop, you have to be the one who determines exactly where all that goes. So what I really like about the cloud is it's extremely user-friendly. It's great if you're sourcing this to a staff member, perhaps, since most of us aren't the ones who are going to be doing this day to day. But this is the intro screen when you load up the Rayware cloud. I have the print set up, and I've already named this demo print. If you wanted to, you could assign the job to a patient, which would just kind of help categorize. Let's say you're doing like aligners on a patient. It'd be nice to have the same patient because you're gonna have several prints with that patient. We're gonna go ahead and select what type of job it is. They got occlusal guard, dental model, surgical guide, other print, which is the little baby Yoda, crown and bridge, and prosthetics. Of course, we're doing a surgical guide. So it's going to go ahead and has quite a list of options here. Generally, I don't touch anything except making sure the material is correct. So it already has the correct printer. You can see if you had a Pro 55, it's going to have a different build platform, 55S, 95, and 95S. So we have the 95S here, so we'll select that. I do want it to auto layout and auto orient my prints. I'm just going to change this to surgical guide resin 3. And 100 microns is the recommended, that's the Z or the vertical layer thickness. 100 microns is great for surgical guides. You could go smaller. It'd be a tighter fit, maybe a slightly more dimensionally accurate print. However, it takes twice as long because it's twice as many layers that we're going to be printing. So 100 microns is great. So I'm going to go ahead and click Next Upload Files. Now I'm just going to drag and drop. You could also browse through your computer, but I'm just going to drag and drop and bring in my file, which is the workshop surgical guide. So it's uploading the file to the cloud. So you can see the bar going across from left to right as it is. And we can see a demo here of it on our screen. Now it's going to also, once it has this uploaded, it's going to think, and you can see here down on the bottom right, next platform setup, and it's counting down from roughly 15 seconds. And it's thinking about where to best align this. It's also putting the supports on for me, which is great. The supports through the Rayware cloud are fantastic, and you'll see that when we take the print off the print bed later in this series of videos. You'll see just how easy it is to remove that. So it's continuing to think, it's syncing changes, it's all going through the cloud right now, and it's going to beam it back to me once it has it decided where it's going to go. Okay, so it's turning green. That means we're close, and here we go. So it puts it right in the middle because it's the only one, which is great. It also knows, surgical guide, it knows somehow, I don't know, AI or programming or whatever, to put it with the intaglio facing up, which is what we want, right? We don't want to have any supports on the inside that we so painstakingly designed to fit the patient's mouth. So I can go ahead and move things if I want to. Every time you move something, it's going to have to resync with the cloud. So I generally don't move a lot of stuff unless I see a reason to. But everything looks good. It's got our supports built in there. Awesome. If we want to, we have a couple options here. We already did the auto layout. We could resize this. You can go up to, that's 300%, up to 200%. Let's say you're doing a toy or you're doing a model or you're doing something you want to showcase to a patient. You could make this a bigger size if you wanted to. I'm just going to go ahead and reset that. Orientation, you could spin this, twist this, turn it upside down if you wanted to. Supports, which it automatically does, a balanced support, which is what I recommend. You can also add and remove individual supports. If you see something that the AI or the cloud didn't detect and you're concerned that you might have a failed print, you could go in and add some supports. Mesh editing, you could plane cut. You can do some more like tool editing, like model editing steps. For most of us, once again, just really just going to breeze right through this. I typically don't touch anything on this whole panel. And then if you want to, you can label your prints, which is nice if you're going to be printing quite a few things at once, right? So I'm going to go ahead and click send a printer because I'm happy with how it came up with it. So it pops up in this screen, it says the name of it here, the printer, the material, just kind of reconfirming all of the selections I made. 49-minute print on standard speed, 46-minute if you have the bolt speed upgrade, which is just toggled on directly at the printer. And it's going to use about 5 milliliters of material, which is not much. I have 2 printers in my list. These are just printers that have been assigned to my account through the cloud. So when you buy a printer, you type in the serial number and all that kind of stuff, and it gets assigned to you. And I can print directly to this printer without having to walk to the printer and touch a button or do anything like that. So if you're really, assured that the resin is correct and the tank is preloaded, everything's good to go, you can just go ahead and click this little checkbox that says I performed the readiness check and I'm ready to go. So if you're down the hall in your office and you want to print in the lab, that works fine too. I usually will hit send to queue, and that's just going to send it over the cloud. It's going to be ready at the printer, and then I'll walk to the printer or have the staff walk to the printer, go to the queue page, which I'll show you in the next video, and make sure that I have everything set up for the print as well. So we're going to go ahead and hit send to queue. It's going to do a couple things. It's going to do what's called slicing, which it's breaking this into each 100 micron layer, and that's the print file it's going to send to the printer. So the printer knows kind of each layer, like each page of a thing that we're printing. And there you go. It's successfully been sent to the printer. So it says, please check the printer for further instruction. We will do that. All right, let's go on back to the printer. Okay, so we're back here in the corner by the printer itself. And one thing that I really like about this PrintRay ecosystem is its ease of use for staff to put things together for you. So with the advent of the S line, they started to have RFID recognition in a lot of the different parts and pieces, which means you're a lot less likely to have print failures based on user error. So what we can see down here, and it might be hard to see on the webcam camera, is a little display that says check resin tank and build platform. And what you'll notice when we open the printer is nothing's installed. So it's letting us know, hey, there's nothing here. We need you to add some stuff. So let's take, for instance, our model tan resin. And we just simply slide this tank and it clicks in. And I've put a little label here for myself to know what resin goes in. But down below on the screen now it says Sprint Ray Dye in Model 2 Tan. So it knows what resin is assigned to this tank because when I first set this tank up, I selected it. Next, we have our build platform. And the 95 series has quite a large build platform. You can easily fit 10 surgical guides and probably closer to 15 dental models on here. But I need to slide this in quite simply. It clicks in, and we have a locking mechanism at the top. So it's now telling me down here to close the lid. When we close the lid, everything's green, says ready to print. Also tells me the temperature in centigrade of the build platform and the resin tank. And that's important because also with the S line, they came in with self-heating models, so it can actually heat the build platform and it can heat the resin tank separately because warmer resin prints better, just like other composite and type resins. So down here, we're going to select the third one down, which is our print queue. And I know you can't see it on the video, but on the very top it says Demo Print. Sprint Ray Surgical Guide Resin 3, 49 minutes, 100 microns from the Rayware cloud. And I simply hit Print. It says go ahead and lock the platform, check the resin, and align the resin tank. I can hit Start Printing at the bottom, and you see an error popped up. The error reads Incompatible material and resin tank. Print this job with Sprint Ray Dye and Model 2 Tan, question mark. You can go ahead and print anyway. Let's say you had accidentally put in Sprint Ray Resin Surgical Guide 2 on the cloud and you had 3 in the tank. You could go ahead and just override it. Or you could say, you know what, hold on, save to queue, let me back out. Okay, I'm going to now swap out my resins because I have the wrong resin in here. And the reason that's important is, of course, each resin, because of different opacities and material properties, needs different types of curing modalities. So different light powers and length of light. So you don't want to print the wrong resin or you'll likely get a failed print. So here we have my Surgical Guide 3 resin. Go ahead and remove the light blocking lid. And it says close lid. You now have Sprint Ray Surgical Guide 3 resin installed. Ready to print. We'll go back to our queue, print, start printing, and there's no error on this one. It's go ahead and it's thinking, and it says warming up. And so it's making sure that everything is at the right heat, which it already was. So it's going to go ahead and start printing. So we'll give it the 45 minutes it has because I have bolt speed installed, and we'll come back when it's done. Okay, so our print has completed successfully. And since we have printed it through the cloud and it's all attached to the Wi-Fi, I actually received an email from my printer letting me know that the print had been completed. So our next step is going to be the wash and dry station. So we have a couple things to note on the wash and dry station. One, it immediately alerts you that you have enough isopropyl alcohol or not, and will tell you if you need to refill it. So the isopropyl alcohol that I get is just from Amazon, and you want to make sure you get 99, at least 97% isopropyl alcohol. So if you are low, it's quite simple. You have the tanks here. There's 2 tanks, the first and the second reservoir, and it'll let you know which one it needs to be filled. We'll go ahead and just add a little bit more to each. Now, as this evaporates or gets dirty, it will alert you if it needs to be changed out. And the wash and dry actually comes with a little siphoning tube that connects down here into each tank to allow you to remove the dirty or used isopropyl alcohol for washing. Inside of the actual cleaning assembly is a basket. So if you were to take a print off of your build platform and just wanted to wash something separately, you could certainly lay them in the basket and then place the basket in the wash chamber. The magnets that are on the lid here alert the machine that it's closed, and you'll see basket highlights. And so we're able to hit start here. It would cycle through the first reservoir and the second reservoir, just cleaning parts that are in the basket. If we're using the platform, since the platforms are built to fit directly into this, and they have magnets also built in, so we'll go ahead and remove our print, and we'll just slide it right in to the wash station. And you may have noticed the little change on the LED screen here now says platform, and it knows that there's a platform attached, and it knows that isopropyl is not going to just fly out of this machine, so it'll allow us to go ahead and start. So we're going to go ahead and hit start, and it'll take us about 11 minutes to get a nice wash. Okay, so the washing and drying is now done. So we have gotten rid of a lot of the excess resin. And now the only thing holding this to the build platform is these supports that were designed via the cloud design service. So all we have to do is just kind of gently pivot the guide off, and the supports simply tear away, and then we'll scrape these excess supports into the trash can with like a paint scraper. But next we're going to insert the sleeves into our holes, and let's go ahead and do that. Okay, so we have our guide once again, and here I have the two sleeves that are going to go into the guide. I have a pilot sleeve and a fully guided sleeve. And if you've been printing long enough and you've kind of tweaked your parameters in your guide design software, these should slip right into the guide with a little bit of resistance, enough that you can feel that it's intimately touching the resin. If that's the case, like it is in my case, I'm simply going to line up the sleeve, give it a little push to get it fully seated. We'll do that on both sides. Okay, so those are now both fully seated, as we can see the pilot on one side and the green fully guided on the other. And since these are nice and kind of well fitted, I'm going to go ahead and cure it straight away. Now, when it cures, the resin is going to shrink just a little bit. That's going to really lock these in. Okay. If after curing, I flip this over and I kind of bang on it just lightly and things are loose or fall out, or if when I'm putting the sleeves in at the very beginning, they feel loose, so there's not an obvious fit, what I'll do is very simple. I have a micro brush that I grab, and I will lift up the lid of the same resin I printed with, just lightly dip in the micro brush, come back to the guide, kind of put just a little dot right in the sleeve hole, and then I will seat the sleeve. And the only thing you want to make sure of is when you flip it over from the underside, there's not resin then blocking the path of the future drills. But just that little bit of resin, almost like a resin luting cement, is all you need. Now, once it's in here, we're going to open up our Procure 2. I just line the base of this with essentially a Ziploc baggie that I just cut the top off of, just so if I have any uncured resin, I'm not dirtying my nice glass plate here, and I can easily change this out as it gets dirty. There's two sides. There's an A on this side, B, and then a middle. And so the fastest curing is in the middle, though if I'm not in any rush, I'm going to use A or B. On the top, very simple selection screen, fully touchscreen LED. I have my most recently used resins here on the top, so Surgical Guide 3. It's asking, do I want to do Zone A, the center, or Zone A plus B? So just depending on the volume of things that I'm curing, I'm just doing Zone A, so I'm going to say Start. So it says, hey, the chamber door is open. So once we close the chamber door, a timer starts, and the light and the heat get going. So you'll see the light is moving over to the A side, which is where the guide is, and it's 3.5 minutes for full cure. Okay, our cure has completed. So we'll go ahead and open. You'll notice the color has actually changed of the guide. Now it's a little bit more of a opaquer yellow. And we're just confirming just lightly that none of the sleeves are loose. Everything's nice and snug. And I happen to have a model for this case, so I can go ahead and just confirm that everything is nicely seated. All right. Thanks for watching on how to do step-by-step on surgical guide in-office creation. Hope that helped. Cheers. All right, I hope that video was really instructive. And so if you don't currently have a 3D printer in your office, you can kind of see just in that quick 18-minute video how simple it is. And it's really come a long way since I started doing 3D printing in 2016. It was a lot more DIY, kind of hands-on stuff. And so SprintRay does a really nice job with the ecosystem and the full package and kind of making it as simple as possible because it should be a delegatable process. So thanks for joining me for this webinar. It's always fun to talk to you guys about guided surgery and 3D printing because it's a passion of mine. And I encourage you to practice your passion and find what it is that excites you about your career because it's something you're going to do presumably for a couple decades. So make sure it gives you a lot of fulfillment. So thank you once again. If you want to follow me on Instagram, that's probably where I'm the most active when I'm active, and it's at Vorholt DDS. And otherwise, we'll see you next time. Thank you.
Amazing. Thank you, Dr. Vorholt, for a wonderful presentation. And thank you all for joining us. This webinar will be available on demand. So if you want to refer back to any of the great content, you are more than welcome to. And we also would appreciate your feedback via our survey that will pop up on your screen shortly. Thank you all for joining us. Thank you for the wonderful presentation, Doctor. And we look forward to seeing you on future webinars.
All right. Take care.